Morning. I say it every year, but we go around and we do science conferences all over the country and the world, and this is my favorite one. This is the one I look forward to every year because it's just amazing interacting with you guys and coming and meeting with you on breaks, hearing your stories, hearing your ideas. I find it extraordinarily personally motivating to me. Are we filming this? This is being filmed? Awesome. The reason I say that is because it's also a great privilege to share the stage with Peter Merkel, who, as most of you may know, is my mentor. He taught me how to care for patients with vasculitis. He got me excited to do research. But there are some challenges. When your mentor looms so large in the field, and in particular, when you share the first name. Because I cannot tell you how many times I get calls at my office because being a federal government employee, my information is publicly available. So my direct office line is on the web. You can look it up and give me a call. And they call because I think they've Google searched Peter vasculitis, and they were calling to talk to the world's expert and quickly find that they got me. But it's not just the phone calls that I get. Now, when you are a physician researcher, we get solicited almost weekly by journals. And let me put this, how do I put this? Journals of maybe not so great repute. The kind of journal that will send you an email and say, for the small sum of $5,000, we're happy to publish your work. And they also solicit you and just say, if you respond to this email, you are now the editor of our journal. And so if you look here, this is the kind of email I get, where it's addressed. Now, Dr. Merkel, as you know, is from the University of Pennsylvania. I'm at the National Institutes of Health. But there is this fictional figure that gets these emails, a Dr. P.A. Merkel, National Institutes of Health, Division of Rheumatology, University of Pennsylvania, Bethesda, Maryland. And I'll read you a sample. I redacted the name of this particular journal to save them. It says, Dear Dr. Merkel, this journal is a peer-reviewed open-access online journal. It goes on to say, in view of your important contributions in the field, we'd like to propose your name for the membership of the editorial advisory board. Just please send your updated CV along with your list of publications. Now, for a long time, I used to respond to these emails and say, I'm really sorry, I'm not Peter Merkel, I'm Peter Grayson. Here's Peter Merkel's email and phone number. But it didn't thwart it. I still keep getting these things. And so now I've taken a different approach, and I just kindly accept every offer that comes my way. So I'm pleased to tell you, Dr. Merkel, that you are currently the editor of about 35 online journals. And I wanted to present you with that knowledge today. But I'm really glad to be here today. We're going to try to ham and egg it a little bit and talk to you about the future and what lies ahead. And I get the easy part. He actually tell you how we're actually going to accomplish some of these things. But my goal is to try to outline for you a vision of what I think the future could be like. And I'm not going to use any slides that show you any data. I'm not going to talk about RNA sequencing, although I would love to if you want to. I'm just going to take you on a trip of the typical patient experience. So I want you to invite you to just relax, sit back, and reflect upon your journey, because I think what I say, you may hear a lot of yourself in it. So I really want you to think about the day that you were first diagnosed and what that felt like. Maybe you were in the hospital, maybe you were in a clinic. For some of you, this was probably many, many years ago. In fact, I really love the buttons that have been circulating. I know some of you are very recently diagnosed, but how many of you out there were diagnosed maybe 5, 10 plus years? Yeah, it's an amazing testament to A, that you're still engaged in this community, and B, that the medical therapy has been what it is. But I want you to think about the day of your diagnosis, and I want you to think about your journey that got you to that day when a doctor told you you have vasculitis, and that's probably the last thing you heard that way, as everything else just washed over you. Some of you probably took weeks, months, some of you years, and I recognize some of you are still struggling to actually find that diagnosis. And part of the reason it takes so long is because of a lack of awareness. And so that's really important that, that there are organizations like the Vasculitis Foundation, that you guys are engaged, because you are ambassadors for the disease. You tell your community members about it. You tell your family members about it. You teach doctors that you interact with. And you know, I think about personally, we go to dinner parties, and somebody will come up to me and say, "What do you do?" And I've stopped answering that question, but I used to say, well, I'm a physician researcher. I study a rare family of autoimmune diseases called vasculitis, and then watch the person kind of shuffle off. And oddly enough, I don't get invited back to those parties. But it's really important that you sort of keep staying engaged with the community, because awareness of the condition really helps to shorten that diagnostic delay time. But that's not everything. And I'm sure maybe some of you had an experience with doctors where you saw one doctor, they looked at that particular organ system. You saw another doctor, they looked at this particular organ system, and it finally took somebody to take a step back and put the whole picture together before you had your diagnosis. And a lot of that is because it's hard to make these diagnoses. And they require a good amount of experience, because there's a lot of pattern recognition to it. And every patient is variable. And what we need is to use research tools to help facilitate diagnosis. We need to train the next generation of physicians how to better recognize these things. The tutu was her idea, by the way. Which I also think that doctors should adopt this book. I think it would make us a lot less intimidating. And if you think about it, think about ANCA. So ANCA vasculitis, the field of ANCA was really revolutionized by the discovery of the ANCA autoantibody, that blood test that can now help doctors more easily make your diagnosis. It can help researchers feel comfortable that you're a similar enough group to be included together in a clinical trial to test if drugs work or not. It can help basic scientists realize, well, there's this antibody that's being made to a protein in a neutrophil. What does that do? Why is that happening? Can we take that antibody, put it in an animal model, and reproduce vasculitis? The answer is you can. And can we learn from those models about the best treatments? And I think in no part, because of the discovery of ANCA, we are where we are today in these diseases. There's a lot of clinical trials, a lot of progress that's happened in ANCA vasculitis. We need diagnostic biomarkers in the other diseases, polyarteritis nodosa, Takayasu's arteritis. We need to be looking for things that will lessen our reliance on pattern recognition and clinical experience, because that's really going to be the key way to shorten diagnostic delay in these diseases. And what about some of you that are outside of the box? I know that there are many of you, I know because I've met you and I've talked to you this weekend, who don't really have a firm diagnosis, or whose diagnosis is called something but it doesn't quite fit. I think you guys are my people, because you represent opportunity. You know, they tell me vasculitis doesn't run in families, but 3 of my siblings have it. That's an opportunity to learn and to discover, and we should be capitalizing on those opportunities. I have disease that's so bad I can't get off of 30 milligrams of prednisone. I'm not responding to the usual treatments. That's an opportunity to learn what's driving that. And I know for those of you that, you know, I also love the buttons with the diagnosis, that's great. And I know some of you, there's probably a little bit of consternation as you're trying to pick the button. I've seen a few of you that have many different buttons, which I think is awesome. But, you know, it's trying to realize the diagnosis, and it's trying to realize these opportunities where the diagnosis is not firm, that we should be drilling down, and we should be really focusing on those patients. I know that most of you have had the experience of, well, we don't really know what to call you, but it doesn't really matter because the treatments are all the same. That may be true, but I recognize how disconcerting that is to hear. So let's say that you have gotten past the diagnosis, and now we're starting to talk about treatment. And I think we should all be very grateful for the last 2-3 decades of work, particularly of randomized clinical trials that have revolutionized the field and changed the outlook for patients with these diseases. These diseases, many of them were frequently fatal, and now they're a chronically manageable condition, in part because of well-conducted clinical trials, because the organization and the efforts of many people who are here today, who have trained me and myself and the next generation of physicians studying these diseases. But there are some problems and shortcomings to clinical trials when you think about it. Because what they do is they take groups of patients. So I have patient group A that's going to get study drug A, and group B, they're going to get study drug B, and I'm going to compare and see which drug is better. And lo and behold, study drug A is better. But at the same time, if you drill down and look at group A, there are a lot of patients in there that didn't respond, that didn't meet the outcome in that trial, who that drug wasn't so effective for. And what happens when you take the data, when you take the evidence from a clinical trial, it gives us great signal of whether one drug or not works in a condition, but it's at a group level. And when you're sitting there in the clinic with your doctor, they're having to make a decision about you. And the best physicians balance that. They understand the evidence, and they're filtering it through the prism of you, your life, your experiences, your risks, your ability to tolerate risk, what your goals are, and all of that. So we're trying in the clinics to personalize these data to yourself, but we need to do better than that. And part of it is because how we approach these diseases is we cluster and group people based on their clinical symptoms, by the pattern of organ involvement. We label your disease based off of a few simple blood tests, but most likely by what your clinical features look like. And we treat in response to those clinical features. We need to add another layer in. And then we talk about big data, and you hear these terms, personalized medicine, precision medicine. What that really means to me is to take your kidney biopsy, to take your affected tissue, and to really study it, to characterize you at the molecular level, rather than in addition to the clinical level, to turn the inflammation that's happening inside your kidney into computational numbers. Because not all inflammation is the same. There's lots of different things that drive it, and they're different across one individual to the next. And if we can start to understand these diseases better at the molecular level, to classify you by a pathway of inflammation, which I think would be an awesome button, by the way, if we had like T and F pathway buttons and interferon gamma buttons. I don't think there'd be big sellers though. But turn that big data into numbers that we can then generate ideas from, take it into the lab, understand the diseases better at the molecular level, and then bring it back to the patients. That is the essence of translational medicine. That's the essence of when you hear these terms, bench to bedside, bedside back to bench, all of these kinds of things. And to do this kind of work, we have to partner together. You guys are very critical to providing these samples. They have to be done in a really timely fashion. They have to be coordinated. They're only as good as us understanding the clinical aspects of your disease. But I think this is where we need to be headed. So you've gotten through your diagnosis, and you're talking about you made your treatment plan, you got put into remission, and now it's, how do I keep this disease from coming back? And this is the question that we're hearing constantly, right? And it's also a testament to how well we're doing. You know, for most of you, the expectation is to get your disease under control with the available therapies. And that's a wonderful situation to be in. But now it's, okay, what do I do? How do I keep this disease from coming back? And I tend to think about that in a couple of ways. The fact that these are diseases that do relapse in a number of patients, the fact that we tell you as your physicians, you know, your relapse risk never fully goes away, you always have to be vigilant, live your life, do what you want to do, obtain your dreams, but you just have to be mindful of it and report, have a low threshold to report back to us. What that says to me is that in many ways, the disease may not exactly have completely gone away, that it's just somewhat lurking there. The immunology that was off kilter that predisposed you to the disease is still present. Maybe there's another hit that needs to get added on to stimulate things. And so what we need to do, I think, as researchers is really focus on remission. We do a lot of study with when you are active, when the disease is floridly active, and we're trying to learn about the inflammation of it. But I think we need to pay equal attention to the times when you're doing well. And that requires us to look carefully during those times, but it also requires us to have long-term follow-up with you so we can see what happens in the future. Those studies take a lot of time and effort and dedication. It's very hard when you're doing research to do long-term outcome studies because it's hard to keep the patients engaged to stick around long enough to see what you need to see over time. If you want to keep the disease from coming back, you got to be able to predict the future. And in order to do that, you have to watch patients for a period of time. So keeping you engaged, I love the fact that there's 10 years plus here. That's an amazing thing, and I think that will facilitate the research, the kind of research that we need to do to answer the pressing questions that are here now. And the biggest one is, can we get this disease from coming back, and can we cure it? And so we're developing different ways to look at these diseases. Still don't know what they mean precisely, but we're looking in different spots. And this is a patient with vasculitis. We're using advanced molecular imaging techniques to actually visualize the blood vessels. This is a patient with large vessel vasculitis. We can't do this with the ankle vasculitis. The blood vessels are too tiny to see with imaging. But for those of you with giant cell arteritis or Takayasu's arteritis, we can actually start looking at your large artery in different ways. And you can see in this person, this is the aorta, the blood vessel taking blood from the heart. These are the blood vessels to the arms and to the neck, and they have color to them. And the reason they have color to them, we think, is because they have inflammation. And we can start to look at you in 3D and spin you around and take a look at your blood vessels. And we can do this when you're feeling well and unwell, and try to learn and look at the disease in a new way visually. If that's too hard to visualize, we can strip away the rest of the body and just look at your blood vessels. And look at this inflammation, or look at this metabolic signal that's there, and try to figure out, why is this here? And we sometimes see this even in patients who are doing well. Does this mean something over the long term? Does this mean that we're detecting little tickles of the disease during the times when you otherwise feel well? I think we need to be focusing in on that area. And I promised Joyce I'd give a slight little plug for what we do at the NIH in our program, just so you have a little bit of understanding, but I won't do this for too long, and I'll turn it over to Dr. Merkel. The National Institutes of Health is a division of the federal government, and when most people think of the NIH, they think about an organization that hands out grant money to scientists and researchers around the world, and that's true. That is the main mission of the NIH. But they keep about 10% of the budget for internal use in what's called the intramural program. The main campus of that is in Bethesda, Maryland, and that's where I work. And this large building that you see in the forefront is the clinical center, or Building 10. It's the largest research hospital in the world. It's a really amazing place because you have hospital beds right next to research labs. All of the staff, from the phlebotomy people to the research nurses, they're all trained in how to conduct research in the face of clinical care as well. It is a place where a lot of landmark discoveries have been made, and but patients who come here have to be invited in on a research protocol. And so I left Boston University 4 years ago now and started a new vasculitis program here at the intramural NIH. And we have a research protocol, and it is a mechanism whereby many of you, I think, looking out where many of you have come to see us, and many more are welcome. It's not a clinical trial protocol. We don't give experimental therapies. It's merely an observational study. We take patients with confirmed or suspected vasculitis, age 5 or older. So we actually do see pediatric patients. We thought that was very important. And we have pediatric rheumatologists on staff too that can help us as needed. I'm a rheumatologist that takes care of adults. We say I'm an adult rheumatologist, but I think that confuses people because it makes me sound like a big boy. We take people with newly diagnosed or established disease. A lot of you have come up and said, I'm in remission, I'm doing well, do you want to see me? Well, absolutely, if the situation is right, for sure, for the reasons that I outlined before. We like to study people at various points in the disease. We have particular interest at the moment in large vessel vasculitis, so all my Takayasu people, that's the one that I've been looking at the most closely. I really think that disease is an amazing one to study, and I really enjoy working with those patients. We look for families with more than one member with vasculitis so that we can do high-level genetic testing, sequencing DNA and that kind of thing, to try to see if we can identify genetic forms of vasculitis, of which more are emerging. We talked in our polyarteritis nodosa session yesterday about a newly discovered
version of polyarthritis nodosa called deficiency of adenosine deaminase 2, DADA2. This is a genetic disease. It runs in families, and clinically it looks a lot like polyarthritis nodosa. That's what these children that were getting it were being diagnosed with. But now we have actually a specific gene that was causing that specific condition. And this gives us ideas that we could then translate and use to maybe understand the broader spectrum of polyarthritis nodosa more completely. And we like to see patients with treatment-resistant disease and see if we can't use some of our research tools to help your physicians guide further empiric treatment decisions. This is my email, and Elaine Novakovic is the research nurse for our program, so that's her email and her phone number. I put this picture up. I showed this picture, I think, 2-3 years ago at the patient symposium, and I added it again, A, because Joyce said the slides would be available online. I thought it would be nice to put out there. But B, because it has my 2 children in it, and my oldest one is getting a little older, and I think that this will start to embarrass her, so I'm trying to get the last bit of mileage I can get. But this is my wife and youngest daughter at the zoo, and nice, beautiful picture of the zoo. And if you look really carefully, you'll notice that in the background is my other daughter, who's now 6, and she is taking off her clothes. She got completely naked within seconds of me snapping this picture, so I was very delighted that I actually caught the moment on. And I use this in talks a lot and try to say, you know, we should be looking in the periphery as well as the obvious stuff, but I won't even try to. I just think it's a hilarious picture. So that's, in a nutshell, I think a vision for the future and what we can do and where we're going. I will leave it to people smarter than me and more organized than me to outline to you how actually we can make some of these things a reality and some of the projects that are ongoing. And we really hope that you'll take from this a sense of community, a sense of support from each other, but also a sense of motivation to participate in the research that's still ongoing, because that's really what's going to get us to the next level with these diseases. We're in a really good place with them, and there's a lot of room for improvement. So thank you.